30 بالظبط. How is it going, the pandemic in your area? Is it starting to be controlled, as in most European countries? Yeah.
Yeah, actually, in the United Arab Emirates, it's almost open. Yeah, because of the expo and the tour. So it's an open country. Till now, there is some social distancing and, of course, wearing masks. But I don't know whether it is rumors or not that maybe within 20 days, maybe there will be no social distancing and no masks.
Okay.
In the UAE, hopefully.
Okay. And what about Egypt? Oh, I think that Katamish has left us. Okay. Yes, in Spain it's more or less the same. I think that in 2 or 3 weeks, everything will be allowed. In UK?
Well, you know, we have so many cases, and I caught COVID myself, and I'm making a good recovery. But it's I think every day we still have several tens of thousands of cases, but we're going to just relax because Omicron has not been too severe, and I think we're kind of pretending that it's not here, so we just live normally.
Yeah, that's what I think too. Yeah.
I think for the sake of time, we can start now. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everybody to the Cornea series and Sinjab Academy Club. And we are honored tonight to have Professor Jose Guell from Spain with us. Jose Guell presently is the Director of Cornea and Refractive Surgery Unit at the Institute IMO in Barcelona, Professor of the Master Program degree at IMO, Autonoma University of Barcelona, UAB, Scientific Coordinator and Professor of the Cornea and Refractive Surgery module in ESASO, European School of Advanced Studies in Ophthalmology, past President of the IMO Foundation, member at the Cataract Academy, the Catalan Academy of Medicine, and director of the European Society of Cataract and Refractive Surgery, the ESRS. Now, I would like as well to thank Professor Qatamish again for his great efforts to make this series happen, and of course, Professor Christopher Liu for his great efforts and presence. Actually, his presence in every session gives a special taste because of the very scientific discussions and the lessons that we learned from him. I'd like to thank as well Professor Gueda from Alexandria University to join us as a panelist. So please, Professor Guell, the stage is yours.
Okay, well, first of all, I would like to thank you for your kind invitation. It's an honor for me to participate in such an activity. And as I mentioned, and we mentioned before, I will focus my talk on deep anterior lamellar keratoplasty. I will share screen. Is it working?
Yes, we can see it.
Perfect. So, well, and there are no financial disclosures related with this particular talk. And I will focus on a specific type of anterior lamellar keratoplasty, but let me just tell you that it was, in fact, anterior lamellar keratoplasty was the first description in corneal exchange in the past. It was in 1840 that Muhlbauer did the first lamellar keratoplasty before Zirm did his first full thickness keratoplasty. The first attempt to expose Decimate was in 1959 by Hallerman, but the first actual reported exposure of Decimate from the front side of the cornea was in the 70s. In fact, the term dark, deep anterior lamellar keratoplasty was originally described in 1984 by Eduardo Arenas Archila, at that time, of course, in a layer by layer dissection manner. I think it is important to say that there has been a progressive improvement in the technique, and the main advantages of such a technique in front of full thickness, of course, when it is indicated, are settled down disadvantages. So there are some articles reviewing the results during the late 90s, where we already started to see the main advantages of dark in front of PKP. And there are, so we can see in 2010, 2012, 2013, a number of series demonstrating the advantages of deep anterior lamellar in front of full thickness, which many of us around the world have working on this technique, including Professor Liu, including Katemish, and many others, have demonstrated the advantages. Not only initially, the advantages were focused on the preservation of endothelium and its immunological and long-term survival advantages, but not visual acuity and visual quality. But as the technique improved, let's say, this advantage that in the beginning had deep anterior lamellar, so time of the surgery, and visual acuity results that were slightly worse for deep anterior lamellar, are not anymore a disadvantage. As you can see, for example, in what appears in this book, I consider one of the best corneal surgery books in the world, the Kratchmer. Today, Kratchmer died and is handled by Manis and Holland. In the edition of 2017, in the chapter, you can easily see that from an endothelial cell density survival point of view, from a graft survival point of view, from a number of rejection episodes point of view, there are clear advantages of deep anterior lamellar in front of full thickness. And from a visual acuity point of view, no significant differences between both as they were in the past, as I just mentioned. These are just a couple of examples because I will focus basically on the technique. Here on the upper left, you can see a patient who had deep anterior lamellar on the right in 2009, and on the left, full thickness in 2014, with a similar cell count. This is one of the best cases for full thickness after 7 years of follow-up. But if you see down there, for example, the case of, on the right eye, a dark, and on the left, a cross-link procedure, you can see that the cellular density is quite similar. In the other two, in the upper right, two cases, there is a significant difference between the eye with a full thickness and a deep anterior lamellar regarding the endothelial cell appearance. So basically, what we know today is that visual acuity and visual quality results are, for both techniques, quite similar. Obviously, this is technique dependent, so these results relies on leaving a decimetric level or not more than 80 microns of residual posterior stroma. Of course, functional rehabilitation time and refractive change are quite similar for both too, because we are dealing with this anterior wound. But the main advantages are chronic endothelial cell loss after the surgery and rejection episodes after the surgery, which basically are in favor of deep anterior lamellar. Of course, there are some indications limits when you have doubts about the endothelial health, or there are very thin, previously perforated posterior corneas. In some of these cases, on the second group, we still can do with manual dissection, we still can do deep anterior lamellar, but in some other cases we cannot. And of course, this technique is not do not escape from complications, as we will see. There has been several surgical approaches described to reach Descemet level. Originally, Sujita in 1997 described a hydrodissection technique, and also from Japan, Tsubota described a once it is dissected to use a divide and conquer dissection, so divide in 4 quadrants on the anterior stroma. Meles described a kind of viscoelastic dissection with a peripheral approach, but it was not until Ambar that in 2002 described the big bubble technique that this technique did not get this, let's say, worldwide impact. So because Ambar create and propose a technique which in most cases give the possibility to reduce the surgical times significantly, because most of the surgical time in the previous with manual layer by layer dissection is for the dissection. So Ambar with his big bubble description gives to all of us a wonderful present. So some others afterwards included some other advantages, some other, let's say, tips, such as San Nicola, Tan, Fogla, and I will focus on one technique, which obviously comes from the original Ambar description, but that instead of using air, we directly use viscoelastic, which I think that has some advantages. Anyway, so here you can see the technique. We take this 300, let's say 2/3 of the anterior stroma out. Obviously, the thickness will depend on the case. And then we directly, instead of inject air, inject viscoelastic. And you create, as Ambar described very nicely years ago, this big bubble. We do not rush at the time of opening the bubble because there is no air, there is no possibility of having Descemet coming up suddenly, because I already have a cushion of viscoelastic inside. The view before you open the bubble is obviously much better with viscoelastic as a dissector instead of air. But obviously, and this is the original Tsubota suggestion, doing these 4 quadrants for dissecting. It's nice to dissect a little bit beyond the vertical cut in order to leave no risk for your cuts and scissors and creating a real vertical cut with your scissors. So obviously, in many other cases, I would say that in about something between 15 and 20% of the cases, you will not get this big bubble, as it also happens with air, and you have a small bubble. Well, you can still, from this small bubble, go and dissect at this decimet or pre-decimetic level the membrane, and more carefully. And of course, always, and this is very important, especially for the new surgeons, always leaving the eye very soft, not a little bit soft, very soft. So these dissection maneuvers should be done under a really soft eye. So especially in young people, you have a paracentesis, you diminish the volume of the anterior chamber, but you need to do it every about 2 minutes or 3 minutes, because the anterior chamber fills quite quickly in young people. And of course, as I mentioned, there are some other times that neither the big bubble nor the small bubble is created with the first dissection. So it takes much longer, and then you try to reach this level, you cannot, but at the end, you will get, as you can see. So it takes some times, but the use of Visco allows you, in the majority of cases, to have a much better view of the anterior chamber structures than using air, at least in my hands. So both approaches are okay, but this is, as I mentioned, my favorite. So of course, if you have an OCT in your microscope, there's a couple of advantages. One is that, as you can see in this upper left video, that you can check the level of introduction of your needle, which is the most dangerous step in this surgery, I would say, because you cannot control depth when you're introducing neither your cannula nor your needle. So if you have an OCT, it will help, and also obviously will help in the dissection maneuvers and at the end of the surgery in order to see if there is any residual double anterior chamber. Of course, as I mentioned, still the technique has its complications, as you have seen in the upper left video. You can, with air, perforate decimet because of the pressure, but also you can perforate with viscoelastic, as you have seen in the lower left. You will see that the perforation will be during the maneuvers of dissection. And the reason is the one that I already mentioned. The eye was not soft enough. And then if it is not soft, there is some resistance on the decimet ball that is created underneath, and you can break it easily. So as I mentioned, the eye should be extremely soft. Of course, double anterior chamber needs to be managed, as you will see later on, but in most of the cases, with a proper management, will be solved. And again, with a proper management of the suture, these folds that, especially in the keratoconus cases, are relatively frequent because of the difference of surface of the size of the surface of the donor and the recipient used to appear in those eyes. With a proper suturing technique, you can put your folds at the periphery. So just a couple of case reports, which I think that are important. So this dissection, you will see, is the standard 2/3 out, then big bubble, then it is not easy, but we create this small bubble in the center. We check with this small bubble in the anterior chamber that there is this posterior dissection, and we start dissection from that point. And as I mentioned, this obviously will take more time because we have not reached with the viscoelastic dissection all the decimet surface. So we are in the pre-decimet level, trying to reach the most posterior stroma as possible, and we will follow, and you will see that we continue, we find another plane, and then we go deeper, and all of a sudden you will see that we will have a rupture. Let me see when it's happening. We have a lower level. We continue with the dissection. Here we are already in these very posterior layers. But again, because the eye is still too pressurized, I will have a rupture here. And then the rupture is not just a peripheral rupture, it's a big rupture coming from one side to the other side. And as you know, these kind of ruptures allows the cement to roll over its surface. But as I mentioned before, despite of these big defects, you can still do deep anterior lamellar. As you can see, I did a inferior iridectomy. I left SF6 20% inside the eye in order to have a good contact. And despite of that, as you can see here, there is a double chamber with a significant stromal edema. And then twice, you can see on the left side the first time, on the right side the second time, twice it was needed to rebubble in order to get a good adaptation of the posterior descemet broken. But finally, as I mentioned, and as happens also in the neck, after 1 or 2 rebubblings, you can have a very good result despite of a huge defect in the posterior descent. So a big or large rupture does not impede that you can still do talc if you wish. This is another interesting case which I'd like to share with you. This is a case that it was not successful enough. The keratoconus case, it was not successful enough with intercorneal rings. So we decided to do deep lamellar. We took these 2/3 of the anterior stroma out first, remove the segments which are implanted really deep, and then we proceed with the visco dissection using the intercorneal rings canal, which sometimes helps to you in this deep dissection, sometimes. As you can see, it was not the case in this time, but at the end we will succeed. Here we have this dissection and this big bubble, and we proceed with the standard technique. So we open, we check that there is a protruding descemet towards the posterior side of the cornea, and we proceed with the dissection, softening the eye constantly. And despite that we know that we are not at descemet level, we think that this is thin enough to get a good residual vision. So we see only some stromal strands. We think that this is enough. We don't want, because this is the only eye of this patient, so we don't want to go deeper. We think that this perhaps might be 30 or 40 microns, and we finish the surgery checking the best possible suture. And look at that. So the cornea is relatively transparent, but we can see this accumulation of viscoelastic in the posterior stromal layers, and which are easily seen on the OCT. So we think that we have this anterior chamber, but the thickness of this posterior layer is too much to have a good vision. So what we decided is to go back to the operating room some days later, remove the anterior, and look if there is any still perforation in the posterior layer, we see that not. Put some viscoelastic and look for trying to be deeper. So we see that we can go through that hole, and we are planning to remove this stroma, plenty of viscoelastic debris, in order to improve the quality of this posterior surface, and obviously to improve the quality of the vision. So you can always come back if necessary, and in a second surgery go deeper. So this is fortunately not very common, but if necessary, you still can do, despite of this previously perforated cornea. So you just leave in the area of the perforation this remaining stroma, but you can make the rest of the surface much clearer than it was before. And this is the behavior. In fact, a couple of years ago, these patients had arcuate keratotomy and cataract surgery. And these are the last photographies that are not mine. They come from the ophthalmologist who takes care of this patient in North Spain. So, in summary, DALK, descemetic or pre-descemetic, as long as you leave an homogeneous stromal posterior layer with less than 80-85 microns, is the technique of choice when keratoplasty is indicated and the endothelium is healthy. I think that there are no concerns today about best corrected and quality of vision. There are, of course, some limitations when there are doubts of the endothelial health, and this is mostly in herpetic disease, or in some cases when there is a very thin or previously perforated cornea, although, as I mentioned, the surgeons skilled on this technique will handle this also in these cases. I think that the Visco-bubble dissection that I saw for the first time, not published, but I saw him doing the surgery, Shimura and then we together described in 2010 this option. I think is less aggressive than using air. You have a slower dissection and more controlled and better visualization. Of course, this is just an option, and this is the option that I am using. And finally, just remember that, of course, if you can, the possibility of having an intraoperative OCT may help you quite a lot in some of the main steps of this surgery. Thanks very much for your attention.
Thank you very much, Professor Guell, for this very nice and innovative technique. And of course, I'm going to leave the discussion to the experts, Professor Qatamish, Professor Lu, and Professor Gueda. So please.
Professor Christopher, do you have any comment on the...
Oh, I am in awe of the videos and the quality of the surgery. I'm a student, so I should keep quiet. But
no, you're not a student, Christopher. No.
It's a very, very beautiful surgery. I think there are some questions, though. I think there are some questions on the chat box.
Okay.
Okay. First one is, does the Visco-bubble makes more pressure inside the cornea as the air bubble?
Probably pressure is not related with the material, but with the volume. Remember that what you're using is a substance that is not absorbed initially, at least by the stroma, and so is occupying a space. So I do not think, I am not a physic, but I would say that the pressure will be more or less the same, and is only related with the volume. So 0.5 cc of air inside the stroma should have the same pressure as 0.5 cc of viscoelastic or 0.5 cc of anything else.
Okay, great. The second question regarding the rupture risk, is it the same in both visco and air bubble and desmatic and pre-desmatic bubble?
No, it's well, yes and no. Yes, you have risk in both. I have, during many years, after Anbar dissection, I was using air, following his technique until I started using viscoelastic. And in both cases, I have had, not very commonly, this is not normal during the injection to have a rupture. It's very uncommon, but you might. I would say that this is more possible using air, because as I mentioned, one of the advantages of using visco is that the injection is more controlled. Normally, when you inject air, you do it in an abrupt manner. So you try you consider that if you do this in this abrupt manner, you will allow the air going deep and dissect decimate. Instead of, when you're using viscoelastic, you're injecting slowly. So I would say that the possibility of having a rupture during the injection is similar. And regarding if you can create easier a pre-decimetic or a decimetic dissection, I would say, at least in my hands, the number of pre-decimetic and decimetic dissection are quite similar with both techniques. So from that point of view, I cannot see an advantage of any of both.
Thank you very much. What's the type of the visco that you used? Is it cohesive or dispersive?
Now, should be cohesive, because the dispersive would, so cohesive also can be not absorbed, but introduced in the stroma, no? But it's difficult. But dispersive would be much easier. It would behave similar to water. So I think it is important to use cohesive, but not high density cohesive, standard density cohesive. There is a question from Professor Goveda. You are in silent. You are in silent. You are in silent.
Yeah. Okay. Thank you, Professor Guell, for this interesting presentation, and I would like to thank Professor Mazen and Professor Leo for the kind invitation. I have just a question. In the absence of, if you don't have an intraoperative OCT, is there a way to know if it is an intrastromal bubble or a type 1 bubble after injection of viscoelastic? So is it possible to know that you still have residual stroma? Much residual stroma?
It is a very good question, and unfortunately, at least from my point of view, without an OCT, it's impossible. Because when you have a posterior accumulation of viscoelastic, independently if this is accumulated in the immediate pre-decimetic or a little bit superior or anterior, I would say, you will have this posterior bulging in the anterior chamber. And that's the only thing that you can check with your intracameral air bubble. So you introduce an air bubble in the anterior chamber, then you see that the bubble cannot reach this area where you have dissected, and then you know that there is a posterior bulging. No, but this posterior bulging may include only decimate or decimate and duas layer, or decimate, duas layer, and some posterior stroma. So no, there is no way.
Okay. So another question: do you think that managing perforation with Visco-bubble is much more difficult than that with the big bubble. So if you are having a perforation in a big bubble, it is easy because you can just unfold the cement and put your graft. But in Visco-bubble, you have a lot of viscoelastic which may interfere with unfolding and with adhesion of the cement. So do you have a technique for addressing this issue?
This is also an interesting question coming from a surgeon that is doing this. So yeah, so it's just try it, and you will see it is really easy. One of the advantages of using cohesive is also this one. It's relatively simple to clean from the surface. Cohesive, just flushing liquid. It is important not to flush it from the top. So the tip of the cannula flushing liquid should be close to the surgical area in order not to traumatize the cement. But it's quite easy to clean the surface from cohesive viscoelastic just using water. But you need to do it, yes.
Okay.
With perforation or without perforation, you need to do this cleaning always. Yes, I agree with you.
Of course, yeah. Okay.
Yeah,
Thank
great.
you.
That was an answer of one of the questions that do we need to clean the viscoelastic before putting the graft? So yes. Am I correct?
Absolutely. Yes, it is very important. Yes.
Mm-hmm. Dr. Khatamish, you were about to talk.
Yes.
Yeah, please.
Thanks, Dr. Guell, for this excellent presentation. Most of the questions have been answered by you, actually, but I have some simple questions for whether you are using the cannula or needle. I watched your videos, you are using the needle. Do you prefer to use the needle rather than the cannula to go deeper and have chances more for getting the Visco-bubble?
Well, you know what happened to me, but this is not coming from the visco, let's say, period of my life, but with the air period of my life. What happened to me is that in order to introduce my cannulas, I needed to use a knife or a needle before to create a small canal and then introduce the cannula. So all of a sudden I thought, well, it is stupid, no? So if I am using, first of all, the needle, and then I take out the needle, and then I put my cannula, well, yes, it was safer because you always consider that with the cannula, it's less, you have less possibilities to have a perforation. I agree, and that's true. But what I decided is just, if I am using my needle to create a space to put my cannula, I will introduce the air directly with the needle. So since the air age of my technique, I am using directly the needle. Yes, a 30 gauge needle.
30 gauge needle.
Yes.
Yes. And of course, you know that I am a great fan of the big bubble technique by air. And I have always, sometimes, of course, I have a failure to get the big bubble after repeated air injection. Do you advise me to try Visco-bubble after too much stromal emphysema, or it will not be easy to have it?
No. I think that once it's exactly that what you the problems that you have with air are exactly the same that I have with Visco. So it will not be. So I don't think that Visco is better than air because of that. I think that failures are the same. The advantage of Visco for me is that when you have failures with air, you have all the corneal surface with tiny, small bubbles that creates a white surface that you cannot distinguish nothing. You cannot see the anterior chamber, you cannot see and if you do it with viscoelastic, the number of failures will be the same, but because of the viscoelastic has been localized in the area where you're injecting, you have spots of grayish viscoelastic deposition, but still can see details of the anterior chamber. And then you can easily see a bubble if you introduce a bubble in the anterior chamber. You can cut, let's say, the viscoelastic area without the fear that if there is air and with this cut you're close to the posterior surface, the cement will come up because you have viscoelastic. So that's what I think is better with viscoelastic, no? But no. I think that the number of failures, as you say, is the same. And I don't think that once you have your cornea whitish, it will make any sense to do viscoelastic. No, I don't think so. Well, you can try and you explain it to me.
Okay.
Great. Can we have type 2 bubble in this technique?
Yes, of course. You will. It's more or less the same. Is that you will? I would say I have not done this comparison, so I must say that I don't know the proper answer. But my feeling is that the number of type 1 and type 2 that you have with Visco-bubble are the same that the ones that you have with air bubbles. I don't think there are a significant difference.
And you have mixed bubbles also?
I've never had. I must say.
Never had. You have never.
I've never had. Conceptually, I would say that perhaps it's more difficult to have viscoelastic going towards the periphery and going dissect underneath. So I'd say it's more difficult. I must also say that I didn't had too many using air. So during 5-6 years, I was only using air. And perhaps I had 3 doubles and not more. So it was not very common, at least for me, using air, but I've never had one with Visco. So I don't know.
Perfect. Any more comments from the panelists? There is a question, Professor Guell. When do you remove the stitches? Any difference?
No. In reality, no. The only difference is that regarding the post-op period is that, of course, as my colleagues will probably share with me, we can reduce the use of steroids, topical steroids, easier and sooner than after full thickness keratoplasty. But from my point of view, the removal of stitches is the same. So I start not earlier than after 10 to 12 weeks, and I used to use single stitches, and I used to remove from that month 2 or month 3, depending on the astigmatism that my patients have, and I never take them out completely before 18 months after the surgery. So, and that's my behavior also for full thickness. Small differences, but for both regarding the age group. So it will not be the same when I'm doing a full thickness or a DALC in a 21 years old recipient that if I am doing in a 89 years old recipient, no? But for both, for full thickness and for deep anterior lamellar.
Great. How do you decrease the IOP in the anterior chamber? Let's say if you need to reduce the IOP many times.
I understand that. This is very important, and this is very important for both air, Visco. I think that Professor Katamish and Professor Liu and all of you and Professor Gobeda will agree. The best is that you should have always, from my point of view, a paracentesis in those cases. And then you should release the anterior chamber. You need to do all the dissection maneuvers with a very soft eye. And as I mentioned, this might be different in young people than in old people, or in between the youngers there will be differences between one and the other. You need to constantly check that the eye is soft and not continue any dissection with the eye. And then the only thing that I do is pressure on the posterior lid of the paracentesis to release some aqueous humor out. And that's it.
Is it easy to inject the viscoelastic with 30 gauge needle in the stroma?
Well, I don't know if it is easy or not easy. It's slowly, and you don't need too much. If this is a standard, that's the reason by what I mentioned that you should not use high viscosity viscoelastic, because then would be very hard. But a standard viscosity viscoelastic can be introduced relatively easy through a 30 gauge needle. Yes.
Question from Manuela. In case of retention of visco, do you always take it out in operating room? And do you wash from one side?
Excuse me, could you repeat the question? Because I have not.
Yes. In case of retention of visco, for example, you saw the patient next day and you found there is a retention of visco. Do you always take the patient back to the operating room to remove that, or do you have any other procedure that you can do it in the clinic?
No, good question. No. I think that you should. You know, I understand why many of my colleagues around the world do many, let's say, injections and rebubblings and cleanings at the slit lamp because of a question of economics, because of a question of that it's easy and takes not so much time. But I must say that I am a defensor of doing everything I need in the operating room. So if I see a significant or not in a corner at the OCT a little bit, no. If I see a significant amount of viscoelastic at the interface at the next post-op day, something that I must say that it never happened. But anyway, if someday happened to me, I will go down to the operating room and clean under the microscope. Yes.
There is a very good question, actually. Which one is more difficult to inject? A case of keratoconus or a case of corneal dystrophy, in which corneal layers matted together?
No, it's the same. I would say that, and I would say that my colleagues would respond the same. The difficulty in keratoconic eyes is not the injection of viscoelastic, which the stroma, of course, that the stroma biologically is different of a keratoconic case than of a dystrophy case. But I don't think that you can feel this difference at the time of injecting the viscoelastic. So the really important thing comparing both situations is not the injection of viscoelastic, but the first step, the resection of the anterior stroma. Because in a very advanced keratoconic eye, you might only, for example, need a couple of turns in order to do this first dissection, because the eye in some areas is so thin that this first stromal extraction is a big problem. And so you might have problems and perforations with this first lamellar cut, not with injection, but with the first lamellar cut. But I don't think that there are significant differences that you can feel during the injection in between a keratoconic eye or a stromal dystrophy.
If you find any retained viscoelastic in the periphery of the cornea, but not affecting the visual axis, do you need to remove it or you leave it?
No,
if you leave it, you leave it.
I leave it. I leave it.
Mm-hmm.
But we should distinguish, when you use viscoelastic, you should distinguish between viscoelastic that is embedded in the stroma that you have left at the periphery, or viscoelastic that is at the interface. What I mentioned before is that if I would see viscoelastic at the interface, I would go back to the operating room and take it out. But if I see some viscoelastic at the peripheral stroma because of my introduction and is inside the stroma, and especially if it is the periphery, I would leave it there because it used to disappear in 2 or 3 months.
Great, thank you very much, Professor. I think.
I have a question for Professor Guell.
Yeah.
Professor, you don't have the passion now to go if you have a straightforward case of keratoconus. You don't have the desire to make a big bubble by air, or you have.
Yeah.
Or your technique is only Visco-bubble only.
No, my technique is only viscoelastic. Yes, yes, because it works. But you know, Katamish, I think that whatever is working for you,
yes,
is good. So you have a huge experience in doing deep anterior lamellar, and you've been doing deep anterior lamellar since Ambar described it. And you've done in many cases, and you handle your air fantastically. So it makes no sense you to change. It's you know. So I only think that it has some advantages from my point of view regarding visualization, regarding speed, and perhaps a younger surgeon might consider, if they are starting to be introduced in the technique, to use this option. But I don't think that someone like you who has so much, no, seriously, I think that we should do whatever is good, whatever is working in a significant number of cases, because we are treating our patients in the best way we can. And I don't think that this is a clear advantage. It's the same discussion that I have with some of my colleagues regarding the psych and the mech. So of course that the mech results are better. But if you're a very good the psych surgeon and you can cut very thin corneas, so results with the psych are so good that why should you make terrible thoughts regarding I should change to the mech, I should change to the mech. It's not necessary. So if your results are good and you're doing good things for your patients, that's okay. That's what I think.
Exactly.
Thank you very much. Do you still have time, Professor Guell, or I think
I would say that
time is over.
Minute, because I have in front of me, you cannot see them, a group of people saying.
Okay. So let's take a last question. In case of leukoma, visco injection could be better because it's more controlled. Is it true?
Well, as I mentioned, without trying to go against air, because as I mentioned, it's a fantastic way to do it. No? In fact, it's the way that is being done by most surgeons in the world. The advantage of going slowly is an advantage for a leukoma and for everything. I think that the slower dissection, I really think is an advantage.
Thank you very much, Professor. Actually, it was a great session. We learned a lot from you, and we would like to thank you very much and for your time that you allocated. We hope that you will enjoy the second meeting. I'd like to thank the panelists, and if you have time to stay maybe for additional 15 minutes to answer the questions, I would thank you all for that. Of course, we will say goodbye to Professor Guell, so you can leave us now. Thank you very much.
Goodbye, and thank you very much. And very nice to see Chris and Katamish and Corena in front of me. So have a good evening.
Thank you. Thank
you. For you too.
I'll say.
So thank you, Professor Lu, Professor Katamish, Professor Gueda. So I think we answered all the questions, but if you like to continue the discussion, it would be great, because we finished early today. I think it's dinner time,
So,
Professor Lu.
Yeah, I want Professor Katamash to say his opinion about the Visco-bubble. Would you like to convert or try it for once, or you are comfortable with the big bubble? What's your opinion?
I think, as Professor Guell have mentioned, since you are mastering a technique, I think there is no reason to change for another one. And for myself,
Yes.
I have a great difficulty to change any steps of my technique, especially if it is successful. So, for example, I'm using 27 gauge cannula of Donald Tan, and I have another cannula of Dr. Sarnicola. I have never tried because I have always success with Donald Tan cannula. So I think since I am doing well with the air injection, I have tried once the Visco-bubble, but it doesn't succeed with me. So I am sticking to my original technique, the air bubble technique.
Yes. I totally agree with you that I think that the big bubble is still the gold standard for DALC surgery.
Yes.
It may be combined with other techniques, but I think everyone should start with the big bubble.
Yes, exactly.
Yeah.
Very good point. So if I want to start learning the technique, do you advise me to start with Dr. Katamish or Professor Guell?
It is not my technique.
Embarrassing question. Yalla.
It is Dr. Anwar's technique, not myself. Thanks for the.
Okay, great.
As Dr. Muhammad mentioned, the standard technique is using the big bubble technique, and there is some tips that you can go through the technique easily. One of these tips that you should have a very deep trephination, and the second tip, you should inject very deep in the stroma, and the third tip, you should use a blunt cannula. If you stick to all these tips, you will be having a great chances of obtaining the big bubble.
So one of the questions was to use the 30 gauge needle for the air bubble technique. Now I learned from you that it's better to avoid a needle, better to go for a cannula. Is there any 30 gauge needle and a cannula, and any need for that one? Because in the air bubble, we need a sudden flow of air. So we need a bigger needle. Is that right?
Most of the DALC cannulas are 27 gauge cannulas. There are well-known cannulas like Fogler's cannula, Sarnicola's cannula, Donald Tan cannula. All of these cannulas are 27 gauge.
To my knowledge, that.
Yes, please.
Yes.
Muhammad, you have any comment, Muhammad? Dr. Muhammad.
The net, I think.
Muhammad may be frozen, I think.
Frozen. So there is no.
No, yeah.
Oh, he's back.
Totally agree. I think there is 5 and even to my knowledge, I don't know if there is available in the market 23 gauge cannulas, and I think 27 is doing the job great. So we don't need 30 gauge cannula, which I think will provide us with a very slow and limited flow of air.
Yeah.
So I think 27 will be the ideal.
Yes.
Very good.
The question in the other way around, does 27 gauge cannula will be good for Visco-bubble? Because Professor Guell advised using 30 gauge needle or cannula. Does the 27 gauge cannula can do the job as the 30 gauge? This was a question supposed to be to Professor Guell, but unfortunately he left us now. What's your opinion, Muhammad?
I think it's worth finding out. You know, in a wet lab, we can get some research or teaching cornea, and then try different techniques, different needles, and see which works the best with a viscoelastic. And I think it's really good that everybody has their own technique and gets good results. But I do wonder, the two experts here, Prof. Katamish and Prof. Guell, do you think that there are any special situations whereby the Visco-bubble technique may, at least theoretically, be better? I'm not suggesting that anybody who's used to what they're doing change, but theoretically, can you see whether there might be some situations when the Visco-bubble would be advantageous?
For me, I don't think so. I think the air injection is doing the whole job. It can be aided by viscoelastic, but only Visco-bubble from the start. I don't, to my knowledge, there is no situation which you will need to start from the with the Visco-bubble.
Yes. But I agree with you, yes.
There is a question, if air bubble, if technique failed to create bubble during operation, can we change to Visco-bubble technique?
That was my question to Professor Guell, and he told me that no, it is not feasible to inject a viscoelastic after too much stromal emphysema.
Yeah. Okay, great.
I think just before we leave, Dr. Mazen, I have to stress that if we have no chance to get the big bubble either by the air or the viscoelastic, we should know how to manually dissect the cornea layer by layer. And Professor Guell has a very unique technique of using the small bubbles as a guide for the depth of dissection. If he can tell us about his technique of using the small bubbles to complete the manual dissection, Muhammad.
Yes, this is a very
has unstable net connection with Dr. Muhammad, I think.
Good technique. Just I want. After having significant stromal emphysema, you just look for the very minute strokes. So it is like this is okay? Not
yes,
yet.
much better, yes.
Yeah. Okay, so after having significant stromal emphysema after air injection, you just look for the stromal bubbles. And you just choose the largest one, which will be the nearest as possible to the peridesmatic layer. You can open on it, and in this case, you can get a very good layer. This technique, and sometimes of using this technique, I used to open the small micro bubbles overlying the peridesmatic layer and inject viscoelastic. And it was working quite good. Then I realized that no need for viscoelastic, just introduce a blunt spatula or a dissector, and it will do the job very good.
And how do you open the bubble, Muhammad? Do you open it by needle or by super blade? Because sometimes it's very tiny and you are risking.
Yes. Yes, I just open it with an insulin needle with the bevel down. So just a small snip, enough to introduce the dissector or the spatula.
Very smart technique.
Thank you.
Okay. Thank you very much for everybody. Thank you, Professor Katamish, for the nice questions, Professor Liu for the nice remarks, Professor Gueda as well for the additions.
Thank you.
And hope to see you next month with a new session, and have a good night for everybody.
Thank you very much.
Thank you for Dr. Mazen, for this outstanding series of teaching for the cornea.
It's a pleasure, and actually I owe all of you for this.
Thank you very much. Thank you.
Thank you.
Goodbye. Assalamu alaikum wa rahmatullahi wa barakatuh.
Bye-bye. Alaikum assalam.
Alaikum salam.